From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today we're talking about how telemedicine is changing the value of healthcare. So healthcare by its nature is complicated, and it can be so hard both for patients and clinicians to sit with inevitable uncertainties in diagnosis and prognosis. And so we're all often tempted to do every test possible. At the same time, we know that not all medical care is useful. So some of what we do is unnecessary, it's expensive, or it even leads to harm, and we call this low-value care. So we're discussing a paper today that examines whether the recent seismic shift in healthcare caused by the adoption of telemedicine is associated with more or less low-value care. And to do that, we're joined today by Dr. Ishani Ganguli, who's an associate professor of medicine at Harvard Medical School, a general internist at Brigham and Women's Hospital, and an associate editor at JAMA Internal Medicine. She's the first author of a study examining the relationships among telemedicine use, low-value care, and spending. So welcome, Dr. Ganguli.
Thanks for having me.
And our second guest has a very different background than our typical guest. So Dr. David Cutler is a professor of economics at Harvard University, a national expert on health policy, and a co-author on the study we'll discuss today. Welcome, Professor Cutler.
It's great to be with you.
And I'll just say it's a personal treat to have these two brilliant and thoughtful guests on the podcast today. And so for some background, let's start with Dr. Ganguli. What's low-value care? Like, what's an example?
So an example would be a prostate or cervical cancer screening for older adults, or an MRI for uncomplicated low back pain.
So a test that might be expensive or have costs, but you're not seeing benefit, or?
Yeah, so a low value test, there's often little to no benefit for patients. So an example of, an MRI for somebody with uncomplicated low back pain, where there are no risk factors or red flags that would suggest a high risk diagnosis. That MRI is costly, it takes patient time, and it can often reveal incidental findings that take you down rabbit holes that you don't want to go down, and yet not help the patient. So that's one example.
And so you looked at whether using telemedicine might increase or decrease this kind of low-value test.
Exactly.
Ishani, there's a lot to unpack in this paper. So could you give us some context? Like, why should we care about low-value care?
Yeah, thank you. So low-value care, as you defined, is tests and treatments that offer patients little or no benefit, yet have potential for harm. So these services are still commonly done, and beyond their direct and cascading harms to patients, they contribute to more medical spending and they divert resources from necessary care. So we wanted to understand how low-value care could be influenced by adoption of telemedicine since the pandemic. And we had two hypotheses, right? So in theory, telemedicine may reduce low-value care by introducing barriers to completing these services at a given visit. So when somebody is not in the office, a clinician may be less likely to order a test, or a patient may be less likely to complete it. On the flip side, telemedicine may expand opportunities for low-value testing by contributing to higher visit volumes and just having more chances to get those tests. So in this study, we wanted to focus on a set of 20 low-value tests that were spanning clinical contexts that are commonly ordered during these visits, are either provided at point of care or scheduled for a later date, and have been linked with both high direct or downstream cascade spending.
And so tell us a little bit about what you found.
Sure. So I want to tell you a little bit about how we constructed the study to give us a sense. So we used Medicare billing data, and we looked at health systems by their use of telemedicine. We divided them into the top telemedicine groups and the bottom telemedicine groups. Then we assigned patients to these systems based on where they were getting care before the pandemic, before they had any chance of picking a health system based on whether it offered telemedicine, to reduce selection bias. We followed these patients from 2019 through 2022, and we compared their use of low-value tests and spending, as well as their use of visits in 2022 versus 2019, using patients in the low telemedicine group as a comparison group. So what did we find? So the main findings, looking across more than 2 million Medicare beneficiaries who received care across about 300 health systems, we found that patients in the high telemedicine systems had slightly higher total visit rates. So they saw their doctor overall more across the year. but they had lower use of 7 of the 20 low-value tests that we looked at, including screening tests like electrocardiograms, metabolic panels, and blood counts and other things. And they had no difference in the other tests. Then when we looked at spending, we found lower spending on total visits and then on 2 of the 20 services we looked at, but no difference in spending on the other tests.
So what does it mean that patients in the high telemedicine group had more visits but less low-value tests? What do we think about why that might have happened?
So I think it speaks to each of the theories I mentioned in the beginning. So when we see that telemedicine was linked to modestly lower use of a number of tests, despite this increase in visit volume that might offer more opportunities for that test, it really supports our first theory, which is that telemedicine visits relative to in-person visits introduce some friction to doctors ordering the tests or patients completing the tests.
And one concern I had when I saw that theory or thought about it is that it's not just low-value care that's harder to provide with telemedicine, but maybe it's all care. And is there harm to the care that patients need, like the high-value care too?
Yeah, it's a great question. And we didn't look at that directly in this paper, but Dr. Cutler and others have looked at it in a previous paper, and they don't find differences in use of high-value care. And what that suggests is that degree of friction may depend on the value of the service. And likely that means that for a clinician may be equally likely to order a high-value test in an in-person or virtual visit, but may hesitate a bit to order the low-value test during a virtual, but not in the in-person.
So to make sure I understand, it's just because ordering a test in the office is just so easy that you might just be inclined to order anything, even if it's low value, but it's a little bit harder to like order an EKG if the person is 100 miles away. Is that?
Exactly. And in support of that, of the 20 tests we look at, some of them, as I mentioned, are usually done in the exam room, like cervical cancer screening or an EKG, and some are often done in an on-site lab, like blood tests. And there are others, like colon cancer screening, for example, or an MRI, that are not usually done on the same site as an office visit. And we find the reductions are really specific to the tests that are done in the exam room or in the on-site labs. So it's sort of in support of this idea that if you're in the office and you're not sure if a patient really needs this blood test, but hey, it's so easy to go down the hall and get it, you're going to go ahead and do that. But then when the patient and you are not physically in the office, it may just not be worth it to order it or to complete it.
Got it. So I'm going to turn now to Professor Cutler to give us a little context on why these findings might be important for our policies about telemedicine in the country.
Great to be with you, Dr. Rittenberg. Our telemedicine policies are all over the map. And for example, Medicare has still kept up parity with telemedicine, but that's something that Congress has to keep reauthorizing. At the end of last calendar year, Congress was set to reauthorize it for a lengthy period of time, but then because of budgetary issues, it was only done for 3 months. So now, as of the end of March, Congress is going to have to deal with it again. Private insurers, some cover it, some don't, some put restrictions on telemedicine, some do not, some pay parity, some do not. And everyone's trying to figure out both what are the cost and what are the health implications of telemedicine. We understand the access implications, which is that for a lot of people, it is really a preferred way of getting care. Sometimes it's maybe the only way, as when people live far away from the doctor. And what are the cost implications? And I think a very big issue in that is how does it affect the use of high-value care and low-value care? And so I think this study is really important because it shows that the low-value care, the stuff that is driving up spending without a lot of value, is actually declining more. And so that really gives an impetus towards saying that we should be encouraging telemedicine, not just going back to where we were and saying, well, that was great during the pandemic, but we don't need that anymore.
Got it. And what are your thoughts about the future in this field? Do you think that there's more research that is needed? Do you think we have enough to inform policy? Where are we at?
So what's happened with telemedicine is it went from essentially non-existent to hugely used, and now it's trailed off quite a lot. The biggest area where it remains very, very prevalent is in mental health care, where a lot of visits are telehealth. But things like routine doctor's appointments, it's much higher than it was. It's below where it was in the peak of the pandemic. And I think there's going to have to be a balancing. That is, what are the circumstances for which telemedicine is beneficial or not. I think it's not going to be a 0 or 1. My guess is it's going to be, for patients, some of the time, medicine is appropriate and other times it's not. What we know is that it's not bad in the sense of leading to more wasted care, missing out on valuable care.
Yep.
And then the question is going to be, how can we make it be as good as it can be? And like many things, that's going to involve health systems figuring out how to use it well, with a backbone of policies saying, yes, we'll pay for this as appropriate, and we're not going to throw roadblocks in the way of doing it.
And are there upcoming policy decisions that you see coming down the pike over the next several months as we're in a new administration?
Yeah, so the Medicare coverage of telehealth is a big one, and that had been pretty clear, but it's now been thrown into some doubt because of budgetary issues. I think also what's going to happen with Medicaid policy is going to be very important, because a lot of individuals who, for example, have difficulty traveling or really have a hard time accessing care on Medicaid, and if Medicaid gets cut a lot, then that's going to put a real bullseye on everything that's paid for that you can get rid of, and telehealth may be one of those. So I think we need the evidence base, whatever it is, to say what we should do. And then hopefully, given that, and I think the evidence base is accumulating that this is a valuable technology and a valuable way to do it. And then hopefully from that, we can say, okay, let's not cut that, but let's figure out how to do it well. But absolutely, it's going to be a part of the mix as we deal with some very, very big issues in the next few months.
Great. And just to wrap up, I'll turn back to you again, Ishani, and just ask you what you think this work means for the practice of medicine going forward.
So I think for the reasons David so nicely articulated, it's really important for us to understand the impact of telemedicine and the widespread adoption of telemedicine since the pandemic. And I do think this study lends some support and reassurance to policymakers that telemedicine will likely not increase overall visit spending. In fact, we find a decrease, and may even contribute to less use of low-value care, and with all its benefits. At the same time, I think back on my primary care practice, and telemedicine is really just sort of in the fabric of the different ways that we take care of patients, right? It's just one of many modalities we use. We're sending messages back and forth to patients. We're having in-person visits. We're doing telemedicine visits. And so I want to end on this notion of this should be just part of what we offer, and to think about it in a more holistic way, and to make sure that primary care payment policies and policies more broadly allow for that flexibility to offer those different services based on what patients really need.
Great. Thank you so much. I'm Dr. Eve Rittenberg, and I've been speaking with Dr. Ishani Ganguli and Professor David Cutler about telemedicine, low-value care, and spending. You can find a link to the articles we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.